Bueno, muy buenas tardes a
Good
todos.
afternoon.
Mi nombre es Susana
My
Koppelman
name is Susana
eh,
Koppelman.
y les doy la bienvenida a todos.
I welcome all of you on behalf of Cegyr, a member of the Eugene Group, to the third virtual Manchester Tribune. It is our third virtual edition. In the past, we would do them in person, and during this version, new novelties in reproductive medicine, we will have 4 meetings and exchange sessions. Today being the first, we have another in June, one in October, and one in November. It's always been the spirit of Sehir to be respectful of scientific rigor in the framework of ethical rules that are very important for us. In this first meeting, this first exchange session, we will introduce the speakers, first level scientists in genetics, and we will share very important notions for all of us. We thank them a great deal to be here with us and to be so kind to share their knowledge. We will review the mechanism, the dynamics. For those that join for the first time, our 2 speakers will have time for their presentations. At the end of the meeting, we will have a panel of experts, leaders, brilliant in their fields, to enrich our discussion. We ask the participants, we are open and you can make your questions, and you can use the question and answer icon. The Andrea and I will be coordinating in order to communicate your questions. So please do use the icon. And of course, you can select the channel because we have simultaneous translation, the channel in which you want to listen the symposium. You have a world icon, you can select the channel, English or Spanish. Now, this is the modality we will work with. I don't want to take any further time. I will introduce Dr. Andrea Cosia, who will introduce the speakers and lead the event. Andrea is a specialist in reproductive medicine, a master in gynecological endocrinology, director of the Fellowship of Training at Cegyr, and coordinates the fertility preservation program. So, Andrea, you have the floor for introducing our speakers. Thank you, Susana. Good afternoon to all those participating of the event. It's a great honor for me to introduce our speakers today. Today we have the presentations by Jennifer Eccles and Diego Marin, and then we will have as discussants Sebastián Menassi and Cecilia Fernandez. Our first speaker is Jennifer Eccles. She is responsible for genetic counseling in genomic prediction. She has a certificate in genetic counseling and has over 20 years of experience in reproductive clinical genetics. The presentation today will be concerns for counseling in a PGT setting. Thank you. You have the floor.
Can you hear me? Yes.
Yes.
Okay, excellent. So thank you so much for having me. It's really an honor to be able to speak with you all and share my favorite topic, which is genetic counseling, and the interaction between genetic counseling and the PGT setting. And it's a very unique area to work in. And I really do love working with the families who come to us for pre-implantation genetic testing. And so if anything, if if after hearing this talk, you think a little bit like a genetic counselor, I'll feel very happy that I did my job, and have you think about some of the things that I think about and that we think about when we're looking at cases and making decisions about whether we're able to accept a case, and more importantly, what does that clinically mean for that couple, and what should they be thinking about in terms of making the decision whether to have testing and how to use those results. Oh. Oh, it's not letting me advance. Hold on. Are you able to advance my, let me try one more thing, sorry. Let me just try one more way of sharing. Hold on. It's not letting me advance my screen. Are you able to help me on your end advance?
On the right, bottom right.
Yeah. I see the share screen, and it's able to let me bring my screen up.
Jennifer, maybe you can try with your mouse.
In the bottom right, you have the arrows.
In the bottom of the screen, on the left, when you
On the right.
presentation, maybe you can try that.
But we are not seeing the presentation now.
Okay, hold on. Do you see this now?
No,
No.
no.
Now you are not sharing the presentation. Can you try to share it again?
Sure.
¿Estás ahí? Isabel, ¿me escuchan? Jennifer, in the green button, please share your screen again.
But I think that it was right. Try again, because it worked.
Can you see this slide?
Yes, 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 that's fine now.
Okay, I'm sorry. I'm very good at genetics, but very bad at technology. So I got nervous when it wasn't moving forward, but I'm glad that you're able to see my slides now, and I apologize for that. So the biggest question that we get when anybody is inquiring about our PGT studies. And when we're talking about PGT studies, obviously that's a very large and broad category. But really what we're talking, or what I'm going to focus a little bit more on, is PGT-M testing. And so the question often comes to us daily is, does your lab test for blank disease? And certainly when we're looking at conditions and making a decision about whether we're able to accept a case or not, that certainly the first aspect of that question is, well, technically, are we able to do this testing? You know, does this require linkage? Do we have a direct approach? Do we need family members? You know, what are the nuances of the case from a technical perspective? The goal of today is not to focus on the technical perspective of testing, though. What I really want to explore today is whether, from a clinical perspective, when we get asked that question, what's going on from our perspective in terms of, does this inquiry make sense in terms of clinical implications, and what are the consequences of PGT testing, and what should patients and clinicians be thinking about when they're making referrals for different indications? So traditionally, when we would be getting requests for PGT back in the day, back in the early aughts, most of the conditions tended to fall into a specific category. There were conditions that had early onset, were always severe, variants were always classified as pathogenic, and there tended to be a 1-to-1 ratio, meaning the variant equals disease. And so, and that was because that's what we had at the time. It always is that the most severe conditions and the most common pathogenic variants are always going to be the ones that come to light first. So that is the reason, part of the reason technically, why that was the focus, and for all of the other ethical reasons why that would have been the focus at that time. But there were no other options. Those were the things that we were being asked to screen for. And that is exactly how it started. In 1992, the very first PGT-M case was a true PGT-M case looking for a specific condition that was not based on sex selection, was looking at a cystic fibrosis case. And both patient and partner were carriers of the Delta F 508 variant, which is a very common variant associated with classic cystic fibrosis. And classic cystic fibrosis meaning childhood onset, severe lung issues, chronic pancreatitis, all of the things we think about when we tend to think about cystic fibrosis. And so when the question comes to us in the PGT laboratory now, does your lab test for cystic fibrosis? That's often what we're thinking about. And it's very common for us to get inquiries for this exact clinical scenario where both mom and dad are carriers of Delta F508 or other similarly severe variant. The genetic report for those cases is fairly easy to interpret, meaning if we have a negative genotype, then we can truly interpret that cystic fibrosis result for that embryo as unaffected. And if the embryo is homozygous positive, we can clearly call that affected. And certainly if that embryo is a carrier and has one copy, then we can call that a carrier and call it a day. And that's something that's easily for the clinical team and patients to be able to see and read and make decisions. From a counseling perspective, there is still lots to talk about within that scenario, that common classic scenario. And when couples are coming to me and talking to me about PGT-M testing, certainly the main goal, my main goal, is to review the benefits and limitations of testing. What is the testing going to tell you? What will it not tell you? How accurate is this testing? Logistically, what do we need to think about? Do we need family members to be included in a test setup? How long is this going to take? What will the results look like? How do we interpret this PGT report? What's the chance of a false negative or a false positive result? And then very important for patients, what's the chance in that cycle for them to get an unaffected and euploid embryo? And certainly we talk about all the time the recommendation for confirmatory testing during pregnancy and the reasons why those recommendations are written on all of our reports. But certainly, as many of us are very well aware, since 1992, there's been a huge leap in terms of the types of variants that we're able to detect through the use of next generation sequencing, through expanded carrier screening, which is very common in the United States for couples who are either undergoing IVF or prenatal testing to undergo some type of expanded carrier screening. And some of these panels have, well over 500 different genes that are on that panel. Whole exome sequencing, whole genome sequencing, these are very common in the States. And because it's very common, that information trickles into the PGT laboratory. And so patients are going to be coming to us for non-traditional indications for PGTM. And I would argue now, probably anecdotally, I feel like the majority now of cases that we're seeing for PGTM, the inquiries we're getting, fall into this more non-traditional role. So conditions that have variable age of onset, severe to mild presentation, variable pathogenicity and expression, reduced penetrance, and there are also implications on whether there's one variant detected or two variants detected within that gene. We'll talk a little bit about, what all of these things mean and give different examples. But so if we're to ask the same question again, does your lab test for cystic fibrosis? What if we make a small switch to the genetic report that we look at? And that is the exact reason why when we get asked a question, does your lab test for? Our answer will always begin with likely, but please send us a copy of the genetic reports and any family history information that you may have, because our analysis depends very much on that, both from a technical perspective as well as a clinical perspective. So for example, this is a case where the patient has the same Delta F508 variant. Okay, we talked about that already, but instead partner has a 5T variant in the CFTR gene, which is exceedingly common. And certainly speaking to a group where there's reproductive endocrinologists and people in the fertility field, you're very well aware that 5T variants in CFTR are common. They're commonly screened for in men who have congenital absence of the vas deferens. And that brings up a very interesting point about this combination. So if somebody asks me, well, what are the potential outcomes for embryos that have both the Delta F508 and 5T variant? It actually varies dramatically. So it can be a child who potentially does have classic cystic fibrosis. There's a percentage of people who will still develop classic symptoms. And there's a percentage of people who may have mild symptoms like mild pancreatitis. There may be males who have congenital absence of the vas deferens and concurrent fertility issues. And there may be individuals who are completely asymptomatic, all within the same framework of these two variants. And so even though it's the same question, does your lab test for cystic fibrosis, what we do with this information varies dramatically now, because now we're not talking about a traditional indication anymore, even though we're still talking about cystic fibrosis. But now this is a condition with reduced penetrance, and meaning not all individuals with the genetic variant will develop the disorder. That's what that means. Or variable expressivity, meaning there's a variety range of symptoms among individuals with the same variant. And so now all of a sudden, cystic fibrosis went from traditional to non-traditional with just that one switch. The reporting needs to be interpreted knowing that, and the IVF clinician and the IVF team, it's important that they know what the variant is and that we're not still talking about two classic variants. So in this case, and this is a report from a couple who was had that indication. So embryo number 2 is completely negative. Embryo number 9 is heterozygous positive, so positive for the Delta F508 variant. And then we have these 3 embryos in the middle that are compound heterozygous, meaning that both copies, both variants were identified in that embryo for those 3. So because we cannot predict for those 3 positive embryos what the, exactly what the phenotype will be, it's very important in cases where a variant does have reduced penetrance, does have variable expressivity, that a couple meet with a genetic counselor or a geneticist or some genetic specialist, somebody knowledgeable with those variants, prior to coming to the PGTM laboratory. And that's actually a rule sometimes that I will put into a case acceptance. If I'm reviewing a report and there's genetic variants that are associated with very potential mild outcomes or outcomes that occur well into adulthood, for example, or there's a variety of depth and breadth of symptoms that may be present based on that genotype, I would like to see a letter from that clinician showing that that couple's been counseled about the actual clinical implications prior to coming to us. One of the misconceptions when people are sent to a genetic counselor at the PGTM laboratory is that we will review all of that minutia. But we're not all, just like in any other clinical field, not all experts in every aspect of every genetic condition. I'm an expert in IVF and PGT, but I have colleagues that are experts in reproductive genetics, experts in cancer genetics, experts in pediatric genetics. And so those voices are needed, when counseling patients, so that I can focus on the PGTM testing with the couple and make sure they have, before coming to us, a good understanding of what the meaning is of that condition. In addition, the PGT report will include the genotype, but not the phenotype. And that's what we do in our laboratory. So if you noticed before, we're not using words like affected or unaffected. So for the 3 embryos that are positive for both variants, we're going to report the genotype only and use the actual term here, compound heterozygous, meaning both variants were detected. And this is important for a couple reasons, and I always let patients know what the report should look like and what kind of words they should expect to see on their report. And the reason we use compound heterozygous is, of course, again, though these 3 embryos in the middle, that the male embryo may have congenital absence of the vas deferens, the female embryos may be asymptomatic or not. And because of that, as the PGT lab, we can't go any further than using term like compound heterozygous. With that said, PGT, in these cases, these common cases, has the potential to eliminate healthy embryos if the couple decides that they would not consider transfer of those 3. And certainly in the case I just showed you, there was 1 embryo that was negative and 1 that was a carrier. Certainly those would be prioritized. But what about couples that only get embryos that are compound heterozygous? What about couples that have failed transfers of those first 2 embryos and are no longer willing or able or have the means to have another cycle? Considering transferring one of those embryos would very much be at the forefront of their mind. In addition, PGT has the potential to reduce the number of suitable for transfer embryos as well, as another way of looking at that. And so it's important when a couple is making the decision about PGT testing that they also understand what the policy is regarding the transfer of positive embryos. In the US, there's a variety of differences in the way that IVF centers treat this. I have patients who I speak to, and they've spoken to their IVF team, and their IVF team is very comfortable transferring embryos that are heterozygous positive, compound heterozygous, homozygous, as whatever the case may be. There's other couples that I speak to where there's a very strong policy against transferring an embryo that's positive for any variant, period, regardless of the pathogenicity and how severe it is. And that's a very important conversation that the couple has to have with their IVF team in terms of making the decision, because again, looking at the complete clinical picture, if a couple goes to the IVF center, and again, they only have or expected to have maybe 1 or 2 embryos to test, and those embryos are positive. If it's a mild or less significant condition, they may very well want to transfer these embryos. And so knowing that ahead of time will save everybody and save couples, in some cases, some heartache, because there's definitely been people who are kind of caught in the crosshairs of decision making because of the differences in what they would potentially like to do in terms of their own decision making and what they're allowed to do at their IVF center. Certainly the legality of all those things and how things vary among different countries. There's a lot more to that, but it's definitely something that a couple should at least know up front what they're able to do when it comes to getting that information. So the decision to undergo PGTM should take into consideration patient fertility history. Is the reason that they're going through PGTM testing primarily because of the PGTM testing? Is there a family history of specific condition that's pushing that decision to have IVF? Or is it the other way around? Are they a couple who has a history of fertility issues and they just so happen to have a concurrent monogenic condition that they're concerned about? What's the age of the patient? Are they worried, or what is, I should say, the age-related risk of aneuploidy? How likely are we to expect euploid embryos? And very importantly, and this is something we talk about with patients all the time, how risk adverse are they? And essentially what level or what amount of information is going to help them sleep at night versus cause more anxiety. Looking at the same question, does your lab test for cystic fibrosis? That one more. So let's say now we have a couple who's, again, patient's a carrier of Delta F508, and dad is a carrier of this 3415A to G variant, which is a variant that came across my desk not that long ago, this exact clinical scenario. When I looked at the report a little bit further, it turns out that this is a variant of uncertain significance. And so a variant of uncertain significance really just refers to a genetic change whose impact is not yet known. We don't know if it has any clinical significance or not yet. When we have a case that involves a variant of uncertain significance, we can no longer solely rely on Mendelian inheritance alone to estimate the risk of an affected embryo. So for example, in this case of cystic fibrosis with this variant, we would say the risk for actual cystic fibrosis may be up to 25%, but we can no longer rely solely on Mendelian inheritance to make decisions. And it's totally possible, again, that this couple has zero risk of cystic fibrosis. It may turn out in a year that they would classify this variant as benign or likely benign, which means that if this were to happen in the future, we would never have even seen it. So one thing we do try to do, if we're able to in the lab, is try to determine if we can tell if a variant of uncertain significance is disease causing or not. And so that's hard to do with recessive conditions because having that variant is not expected to cause disease, so there's no way to track it. But for dominant conditions, it's a little bit different. And sometimes we can, in the laboratory, at least get a sense for counseling purposes if we can be a little bit more reassured that the variant we're being asked to evaluate is truly the disease-causing variant in this family, or if there's little or no evidence that that's the case. So for example, we received an inquiry for a case to address hypertrophic cardiomyopathy. The partner's positive for this condition, he's clinically affected, and genetic reports confirm that he has a variant in this MYH7 gene, which is a gene commonly associated with this condition. Now, this alone in its own bubble doesn't tell me very much, but in assessing the family history, his brother, his mom are affected, and they too have the same variant. He happens to have a sister who's negative, and she does not. So in counseling in this scenario, I feel pretty good. Now, it's not 100%, it's never 100%, but I feel pretty good that this request for PGTM studies is smart, is valid, and that if we're screening for this variant of uncertain significance, we are likely looking for the right thing, not 100%, but likely. And so it's reasonable to exclude embryos that are positive for this variant. It's reasonable to undergo testing, and it makes sense from a clinical perspective. Now, all of that goes out the window a little bit if, let's say, we change it up a little bit and the sister's positive. So in that case, we're a little bit less sure, or maybe a lot less sure. It kind of depends. It's possible that then we could say that the variant of uncertain significance, it may just be a fluke that the affected individuals all have it. It could be that the sister's younger and perhaps she just hasn't developed symptoms yet, but maybe will in the future and will end up being a positive individual. We don't know. And we're only as good as the information, of course, we're presented with at the time that we're evaluating a case. And so either way, from a counseling perspective and thinking about PGT for any variant of uncertain significance, patients have to be informed of the possibility that negative embryos may still be at risk for that familial condition. And that certainly makes sense, but it's not always clear until we have that discussion that is indeed one of the risks of screening for a variant. I mean, truly any variant, even if it's pathogenic, theoretically, that can be the case as well. We're always trying to make sure that what we're being asked to screen for, especially when it comes to a dominant condition, is truly the reason for that condition in the family. So moving a little bit forward, then let's change it up a little bit. And if we ask the same question, but now we're asking, does your lab test for hereditary breast cancer? Well, we can certainly look at that too. And most of the time when we're getting an inquiry about hereditary breast cancer, usually when we look at the report, it is a BRCA1 or BRCA2 variant that we're getting asked to evaluate. And this makes sense. It's one of the most common reasons or monogenic causes of cancer, hereditary cancers, and women who are positive for a variant have a 50, and upwards % chance of developing breast cancer and ovarian cancer. And so it's a very common reason we may get a request about hereditary breast cancer. That's not the only one though. Certainly in this day and age with next generation sequencing, with all of these huge hereditary cancer panels, we get requests for all sorts of genes associated with cancer. ATM happens to be one that we see in our laboratory all the time. And it's close, I would say it's related to BRCA1 and 2, but this one is considered more of a lighter or moderate risk gene, where women have about a double risk of breast cancer. So important to know, because again, patients who are coming through our laboratory, there may be more of a reason or of an impetus potentially to transfer embryos that are positive in this scenario, for example. And certainly male embryos, knowing whether an embryo is male or female, plays a huge role too, because transferring an embryo that's male for either one of these variants, the cancer risks are lower compared to females. On the reports, it looks similar to what I showed you before. Similar idea, we're not going to report phenotype because these are also examples of conditions that have variable penetrance, variable expressivity, but we will report the genotype, and that is clear enough usually, certainly, to be able to know whether the variant's there or not there and make clinical decisions. This is what an ATM report, for example, would look like. But we recently actually got a very interesting case a couple weeks ago. And it started out as a hereditary cancer syndrome case. The patient's positive for a variant in the ATM gene. She was screened because she does have a history of cancer. She underwent one of those large cancer panels, and this ATM variant popped up. And we counseled this couple about testing for ATM variants, testing for PGTM, how that works, and went through all of that, and they submitted their saliva samples. And around the same time, they were also undergoing expanded carrier screening. And on the expanded carrier screening panel, of which ATM happens to be part of that panel, he was also identified as an ATM carrier. And so clinically, this changes the situation actually quite a bit, not just in terms of their risks of passing on an ATM variant, which certainly has gone up, but also now they're at risk actually for related, but actually very, very different condition. And so this embryo, the last embryo, number 38, is positive for both the maternal and the paternal ATM variant. And in this case, we actually, as you can see, we didn't use the word compound heterozygous. We actually upgraded it to affected, but not affected for hereditary cancer syndrome. This is actually an embryo now we've diagnosed with a separate condition called ataxia telangiectasia. That's part of the reason why the ATM variants are also on expanded carrier screening panels. Ataxia telangiectasia is a childhood onset condition, very different from having one copy of the ATM variant. So all of a sudden, this couple went from being worried about possible risks of increased cancer later on, and in our discussion thinking that, you know, they would want to triage their samples, so they want to know about the ATM, the maternal ATM variant, but if they only have embryos that are positive, they would transfer those. And, you know, having a very clear idea of what their intentions were with regards to testing. And then now having this additional information, actually finding out that they're actually at risk for a childhood onset condition, and the risks of having, or the chances rather, of having an unaffected euploid embryo are significantly different than what we initially thought. The reason I'm bringing up the ATM example is that this is most definitely not limited to just ATM variants. So cancer risks and reproductive risks, we're learning now, are actually very well intertwined. And this is a small example of actually the myriad of different genes that fall into this category, where if somebody is heterozygous positive, we worry about inherited cancer syndromes. But if a couple both are carriers of a variant in that same gene, we're actually worried about early onset recessive conditions. And this is really important to understand from a clinical perspective, because actually a lot of patients are not being informed of these risks. And it changes what they would do clinically and how they would look at their results clinically, certainly. So patients need to understand that different genetic conditions with different inheritance patterns are possible, even if we're talking about the same gene. And patients should definitely be made aware of the availability of partner screening to assess these risks, particularly if they're willing to transfer a positive embryo, like in the case I just explained, where they would certainly consider transfer of an embryo positive for the ATM variant. If a couple is not going to transfer at all a positive embryo, period, then you're also reducing, reducing the risk of that recessive condition. But if transferring a positive embryo is a potential possibility, then this discussion should be had with patients. And certainly, I mentioned it earlier, but the risk of identifying an unaffected embryo are lower in these cases. So looking at the same question, does your lab test for breast cancer? And the follow-up to that in the email we receive in the laboratory is something along the lines of, you know, there are no monogenic causes of breast cancer in this family, you know, and the question is there anything we could offer this couple? In our laboratory, the answer is yes. We do have polygenic testing through our laboratory, or PGT-P, and the difference is certainly that looking at a BRCA1 or BRCA2 or any variant associated with hereditary cancer, you're looking at single gene and single variants, or more than one variant, but in that single gene, versus polygenic testing, where we're looking at genetic changes tiled all along the genome and weighing the presence or absence of those individual variants in order to calculate a polygenic risk score, which is essentially using that information to estimate what the risk would be for that individual or that embryo, or however you would be applying that information. So from a PGT perspective, essentially the main goal is trying to attempt to get a relative risk reduction. If there are a cohort of embryos, how can we use this information to pick an embryo that has a lower risk relative to the other embryos in that cohort? And we can look for breast cancer, as well as a number of other conditions that fall into this polygenic category. The testing, and this is important, the testing is done on the same platform that we would be doing PGTA studies. And that's important because the polygenic testing should not be performed in a bubble. It should be performed in conjunction with ploidy status, the same as PGTM studies. This is what an example report would look like for a patient if I were counseling them. And the main piece of information when it comes to these polygenic risk scores is this score that we call an embryo health score. And an embryo health score is our way of taking all of the different polygenic risk scores for breast cancer, for other cancers, type 1 and type 2 diabetes, certain cardiac risk factors, putting them all together and using a single number to help couples essentially triage or order their embryos. So the average embryo health score is 0. Anything above 0 is considered better than average, and below 0 is considered worse than average. The goal, though, is not to say a score is bad or that there is a bad embryo. We would never tell a couple, for example, that they shouldn't transfer any embryos on this list. But really, the goal is to help couples, similar to PGT-M testing in many cases, to triage their samples. Well, what should we start with? Which embryo has less risk compared to the other embryos? So in this scenario, it would be the first embryo, embryo 25, because that one has the best score. From a counseling perspective, and we talk about this a lot with couples, this is a test best used as a tool for comparison and selection, not for diagnosis. And I hope, as we've already talked about, that the idea of PGT-M for diagnosis is becoming less and less common. And the idea that it's a screening tool is becoming more and more common, the more that we learn about genetics in general. But it's definitely a tool for comparison. It is not a tool to make a diagnosis or give a yes or no answer at all. And it's best in cases when there's more than one embryo to compare with. Otherwise, you don't have a comparison. You don't get any relative information. So it's best in cases where multiple euploid embryos are expected. Unlike PGT-M studies, a personal or family history of a specific condition is not needed. So they don't have to document a specific condition in their family or provide genetic reports like you would need to for a PGT-M study. But, and this is a very important but, if there is a concern about a particular condition based on a strong family history, so if, for example, a couple comes to me and say, well, we're interested in polygenic testing, you know, we have some breast cancer concerns, and then in asking them more questions about their family history of breast cancer, they say, oh, my sister had breast cancer at age 30, and my mom had, you know, ovarian cancer at, you know, 60, and you know, my maternal grandmother had breast cancer, and it starts to sound very suggestive of a potential monogenic cause of disease, then monogenic causes of disease should still be ruled out and should still be, they should still go for testing and have a, you know, a panel and speak to a genetic counselor about their actual breast cancer history. So polygenic testing will not at all replace monogenic testing in that way, and nor should it. It would be a mistake if we have a family with hereditary cancer syndrome to perform polygenic testing without monogenic testing. So hopefully through all of this discussion, I've explained a little bit about all the different reasons why I think about PGT testing really now as a vehicle for risk reduction versus a vehicle for diagnostic testing. Certainly, it's diagnostic in the sense that we're very good at identifying genetic variants. And in many cases, we have the technical capacity to identify a specific genetic variant. But clinically, in many cases, and these cases arising, the more whole exome, whole genome, expanded carrier screening we do, that it really is a tool for risk reduction. And I consider this testing really in my head, what are we going to do and how can I counsel this patient about embryo prioritization versus, in some cases, embryo elimination. Certainly genetic counseling is, I'm biased as a genetic counselor, of course, but certainly genetic counseling is a very key component of all of this. And we encourage any families coming through our laboratory to have genetic counseling. We try as much as possible to counsel patients ourselves. And when that's not possible for a variety of different reasons, we hope that patients have genetic counseling with a local genetic counselor, because it really is a key piece of this whole puzzle to set expectations and limitations and explain the entire process so they can truly fully consent to this testing. And with that, I say thank you so much, and thank you again for the opportunity to speak to you all today. I really do appreciate it.
Muchísimas gracias.
Thank you very much. It's been an excellent presentation. Thank you, Jennifer. It's been excellent presentation. Very interesting indeed and very complex. So thank you for sharing all your experience. Now we will continue with the following presentation by Dr. Diego Marin. He is the head of clinical development and research, reproductive genetist, assistant laboratory director, has published over 30 articles in international journals. Thank you, Diego, for being here with us. And we can start your presentation. Thank you. Can we see the slides? Thank you for the invitation. It is a pleasure for us. Today, the title of my talk is PGT, the end does not justify the means. And reviewing with the team, perhaps this may give a different message depending on who reads it, but my point is focusing on the technical aspects of PGT and showing why, although as an embryologist, as a physicist, we see PGT as the PGT test, which is done on many patients. There are many ways of doing PGT. So this is what I talk about, giving an overview of the complexity of the PGT laboratory and why it is important to know the platform used by our clinic. The conflict of interest, I am full-time employee of genetic prediction. It's very important because PGT, fortunately, is a practice that is becoming routine in the US. This is a report from 2018 where 40% of the IVF cycles are done with PGT. In 2018, we estimate that given the quality of this test and the benefit brought to the clinic. Now, I show this slide because we as embryologists, we know when to do PGT. You take the biopsy of perfectoderm, take the kit, and then ship it in the same country or internationally. So here, to know what happens. So the samples that go to the PGT laboratory, sometimes it is a black hole, whatever happens as long as the report comes. So obviously, it is something that is so because we do it practically, because it's very important for clinical directors, medical directors, embryologists, before using a PGT platform, to be informed of what is the type of analysis being done and what technology is involved in the platform. Because one of the major errors with of many people we have talked to is not only the doctor, the embryologist, the personal doctor, that we take PGT as if it were a single test. And we use it as an umbrella that encompasses different techniques, different equipment, that we are not all trained to understand them. And simply to give you an idea, there is a number of instruments to do PGT. This is one of the most broadly used, NGS, Thermo Fisher, and then we have high productivity, Thermo Fisher, qPCR. So this is the for you to understand, it's not done by a single means, but there are many ways of doing it. So this about the platform. Not only go into details about the methods of DNA, because there are many kits for DNA amplification and they all have different chemistries. So maybe a chemistry that permits to do more genotyping studies or one that permits a more number of copies. It depends on each platform and simply to exemplify how variable this is. Now we have the other umbrella, the large number of competitors, of vendors that offer PGT equipment. And I show this because PGT has an advantage and a disadvantage. A major disadvantage is it is little regulated, at least in the US, because it is not done in a human being sample, not in the actual embryo. Many countries in Latin America, we do not have even legislation. So this is a disadvantage because it happens that there is a number of vendors, it explodes and different prices, different details. It's an advantage because it helps us move forward. So simply, this is to show that in the day-to-day, we encompass everything under this umbrella. But PGT has each platform, each vendor has to be transparent and tell the clinic what they are offering. So simply to close this, and that is what happened in the IVF lab when you take the sample in the tubing process. The sample, when it gets to the laboratory, starts a complex process, not overnight. And simply, I brought something to illustrate, at least in our case, when the tubes arrive, in our case, with a QR code, they identified per patient, they are scanned. We talk about a high complexity laboratory, but the laboratory of PGT is also high complexity and has a lot of regulations. In this case, the sample arrives, it is recorded in the system, and then proceeds to the first step. That is quite conventional in most laboratories. The first step is pre-amplification of DNA, because let us remember it is a 5-cell biopsy. To work on this, we have to amplify, so there is pre-amplification. So as you can see, we did this done in a laboratory with a lot of security, and then follow-up, track the sample. And then when this pre-amplification takes place, the second analysis starts sequencing, or then through SNPs microarray or PCR. And this is in a different space, the PGT laboratory, and takes has bioinformatics weight. That's and then the algorithms, the analysis of the data. There are software that are commercially available, and others that are created by each laboratory. So I would like to make it clear that there is a number of methods for PGT. And at the end of the day, it's important for each clinic to know what it is about. So finally, this summarizes in a report, in an outcome report. And I will not go into details, but yes, I wanted to show and two aspects in which the platform varies. One is the resolution, the type of data that are obtained. And here I show you one of the main platforms that have been used so far to do PGT. One is qPCR, or the real-time PCR, in which only 4 regions were being amplified by chromosome. We had about 96 sample probes of the whole genome. And in spite of that, in spite of having relatively low coverage of all the whole genome, we obtained PGTA. So it's 4 positions of the chromosome. And then next generation sequencing is a more focused amplification in which that amplifies certain areas of the genome. When the platform was created, 400 positions per chromosome average. So the resolution increases. The CGA array, I was trained with Dr. Carmen Rubio when this was starting, and it's a platform that is quite difficult to do, but with a much higher resolution. And then the next generation sequencing that we use, because it lowers the cost, with about 20,000 positions, genomic positions, and the SNP array that is tends to have more resolution because we can reach 100,000 polymorphisms. And so simply before continuing, let's remember that when we talk about SNPs microarray, there are two, one the old and one high throughput that has a greater resolution. So, but that's one of the aspects in which PGT platforms vary. Something else is cost. And this is quite important because the scientific committee does not tend to see this, but it is important. And as you can see here, one of the reasons for which certain technologies have this have been left aside because of the cost. So I show this just for you to see that platform. It doesn't mean that one is better than the other, but give different data. And the clinician in biologist has to know this is what the platform will give me, and this is what will not give me. And now to conclude, I like to show, and always talking about the importance of validations when when we develop a clinical test, because we are talking about a medical test, a clinical test that has to take the analysis, know the sensitivity, how specific the test is. I recommend this article written by James Jallas about the steps or the good practice when developing a PGT test. So this is one of the three main pieces of evidence or necessary steps. In summary here, first, validation, analytical validation. Analytical validation is we have the machinery, the chemistry. Let us use positive controls to see if we obtain the same result, and they can be cell lines or rebiopsies of several embryos, and we have original result. And then it is quite important. They are not so complex experiments, and in spite of this, not everyone publishes them. And I understand when we talk about PGT, so many algorithms, many of these things are patent, proprietary algorithm. They are patented, but it's true but to a certain extent because there is a number of data that are publishable, can be published, and like analytical validations, it's not proprietary. I process this sample with this platform, I have the expected result. Unfortunately, not all laboratories do this. And in generally, we always recommend clinics to request for this and to go to the article in a peer review article. So this is important. And the second piece of evidence is more difficult to achieve. The clinical predictive value of the test. And when we do PGT, we take a biopsy, a 5-cell biopsy. We take a karyotype. It's the embryo is normal or abnormal. And many that are against PGT say it's a biotrofectoderm biopsy. How can I be sure that it'll have the same karyotype? It is true. We will never be certain unless we do sample the internal sample. But this is a clinical test, and physicians may know that when you do it, you want to know the label the test is giving me in the sample. What predictive value does it have? If a PGT is telling me euploid, well, I'm interested in that label, what predictive value it has, or negative predictive value. And an example of a study, a non-selection study, is published by the group of Dr. Scott. They transferred biopsed embryos without clinical results and then analyzed the biopsies. And once the patient were pregnant or had lost the embryo, and there, well, they did analysis much later, and then you can determine the predictive value and the result of employed and employed. And they observed that those embryos rated employed negative predictive value was 100%. And whereas the positive predictive value of calling the embryo euploid was 65% of the pregnancy rate. So simply a type of extra clinical validation that no all can do, because this is a lot of work that involves approval of the ethics committee, money. Not everyone can do it. But if we have the PGTA platform that uses the same chemistry, perhaps giving a look and being certain about the clinical data. And finally, the gold standard that we all want in any clinical test is a randomized control study trial. So whether it is a difficult trial, Jennifer knows that we have an RCT very complex because it takes bureaucracy, a lot of sites, it's got to be multi-center, but finally it is the gold standard that gives the answer if the test is useful in the clinic. And what I show is that there have been in other fields randomized control trials that for RCTs to work and give us good answers, it's got to be well designed, excellent design with people who know what they are doing and being very homogeneous in the PGT platforms. Because what has happened is that the articles we have so far are from certain groups that do them in their clinics, and like the trials by Dr. Scott with positive results. But then when we have many sites with a lot of different platforms, like the START trial, we saw negative results of PGT in patients that were not advanced maternal age and say, well, PGT is no use. No, if we read this paper carefully, we can see it was many sites, a lot of PGTA laboratories, and some reported, another student did not, others had different cutoff points. So considering PGT as a single thing, the study was not correctly designed, and then there can be false conclusions. And finally, this interesting study presented by Dr. Klaus Bimmer in Baltimore last year, where in his clinic, the one that was in, they developed an independent study. They sent for some time 3 groups of patients with the same demographics to different PGT laboratories using different technologies like SNP array, etc. 3 different laboratories, and what he observed was the clinical results, like the rate of aneuploidy, the percentage of cycles, pregnancy rates, and even loss rates were completely different among the 3 PGT laboratories. And all, as I say, embryos stayed from the same clinic with a homogeneous population. So this brings more emphasis on what I said before, that when you establish a PGT program, review very carefully, compare with other vendors the clinical results that are best for you. And this is not the point of this talk to talk about mosaicism, but mosaicism, I have to mention it, is one of the big topics that has been abused in our field, because even if it is a phenomenon that takes place in nature and implantation embryos, PGTA has made it promiscuous. We have done several studies in which, and this is predicted by certain platforms, where making studies of the original biopsy, you can see a distribution of embryos, as I show here, 28% euploid. When doing a re-biopsy analysis, these proportions change. Euploid reaches 30%. 30%, you can say this is expected based on mosaic. If we take many samples, we have different results. But what happens is that studies like Dr. Capalvo done in Europe observed that implantation rates of euploid and some mosaic embryos were the same. So what is the point here? That some PGT platforms offer certain add-ons, certain predictions that, if not well validated, they are launched to the market, or perhaps they create a problem when the clinician should not have that problem. And those mosaic embryos very likely were euploid to begin with. And this mosaicism could have been found or the result of the platform noise. And finally, the typical complex or chaotic patterns. Another result we get in PGT, we have seen in our data that these data vary from platform to platform. We did a study where embryos were rated as complex, aneuploid, or chaotic by next generation sequencing platforms with several biopsies for per embryo in a different platform with higher resolution, like this one, with 56% of those embryos were euploid, as confirmed by the 4 biopsies. It's important and concerning because it says that maybe some platforms that call chaotic to a very noisy sample that should be non-conclusive. So simply, this is the message. Let's remember that PGT is not always the same. There are many different technologies, and simply to thank the organizers, my team, Jane Eccles and Nathan Treff, our laboratory director. This is my contact if you have any questions in the future.
Bueno, muchas gracias, Dr. Marín.
Thank you so much, Dr. Marín. Brilliant, very clear presentation, also very interesting. So now we will go on with our session. We will now have the Q&A and comments. I will introduce Dr. Sebastián Menassi. He is a physician specialized in genetics with a master's degree on molecular biology. Hi, Sebastián. How are you? Welcome. Also, Dr. Cecilia Fernandez. She is a biochemist with a specialization in genetics and also a PhD on genetic biology, and also specialized in reproductive medicine at Bionogen.
Buenas tardes.
Hi, good afternoon. Let's be traditional and ladies go first. What do you think? Well, thank you so much, both of you, for your presentations. Very illustrative. And Jennifer, I really liked the CFPTR pathology, which seemed simple to solve, but in variants with different penetrances. or different modulators become much more complex, especially the 5T, which is very complex, and it's very difficult to convey the different concepts and new concepts we have in genetics within the world of variants that cannot be cataloged, whether they're benign or pathogenic. They're like in the middle, the gray zone. So my question, which is a general question, basically, what pathologies, what types of pathologies or mutations do you think that are still not yet be able to be addressed with PGTM? We have a lot of techniques available in molecular biology, and considering the limitations in the amount of embryonic DNA that we can get, which I believe this is the main issue, still, there are some, I mean, which would be the mutations that are undetected, or at least in your experience, what are the variants or mutations that cannot be addressed with this?
That's a very good question. And there's two ways. I'll answer it more from the technical perspective, although people will probably give a very different answer if the question is more from an ethical perspective. From a technical perspective, the reality is we can actually really address the vast majority of cases in general. But it doesn't come down solely to the specific variant. Sometimes it comes down to whether or not, for example, if it's a triplet repeat expansion disorder, where there is no specific variant we can focus on. In our laboratory, we would need some sort of linkage plan. Linkage meaning we need to be able to figure out, where did this expansion come from? Did it come from mom? Did it come from dad? Can we link this to a child? So we may have 3 inquiries about, let's say, Fragile X syndrome or Huntington disease or whatever the condition may be. And we may say 3 different things to that couple depending on their actual family history, which less has to do with the specific variant, because technically we can do it. But potentially if the family history isn't cooperative, then maybe we can't. Other things that are difficult for us are changes that are de novo, meaning only in that individual, and we can't identify a specific direct method that wouldn't require linkage, because if it's de novo, of course, we don't have family members. So for example, an example of that would be a duplication that was de novo. Those are tricky. So those are some examples. So luckily, sometimes we can get away with things by using family history and the pedigree to be able to design something. And other times, even for the same variant, we may not, and so that's the trick. The other thing I will say that's a little bit tricky is sometimes variants, when there's a pseudo genes, meaning genes that are near that gene that are kind of copies of that gene, but are not actually the predictor of the disease, that can also be tricky. Doesn't mean we can't do it, but we evaluate those cases on a case-by-case basis. Many times we are successful, but not 100% of the time.
Gracias, Jennifer.
Thank you so much, Jennifer. Another thing that I really liked is that you underscored or you emphasized that you do not use the word affected or unaffected in your reports, but rather the genotype, which from the lab is what we can really see. But the same thing as happened with PGTA. Most labs use the word normal, but we know that normal in genetics, it's quite difficult. I mean, it doesn't exist practically. So in your experience, in the reports, you add some extra or additional information as to what it means that it is heterozygotes or compound? Do you provide phenotype details? Because it's not so easy to change this mindset in not including this very simple interpretation of affected or normal. And sometimes it's not well received. I don't know, in your experience, have you handled this?
That's an excellent question too. So yeah, the quick answer is absolutely. On our reports, we write a whole, for PGTM cases, we write a whole paragraph explaining essentially the history of that case. And so, for example, that complicated case where both members of the couple were carriers of an ATM variant, on the report, we define compound heterozygous, affected means ataxia, telangiectasia. That's what we're worried about. Heterozygous means at risk for ATM-related cancers. Negative means this. And we do that on every report because it's absolutely true. We don't expect everybody to be geneticists when they're reading our reports. We want the reports to be interpreted by a wide variety of individuals, including the patients themselves. So we do definitely put that information. We definitely do get calls, though, all the time. And we do welcome these calls. And we are always trying to find ways to make reports more readable in general, but we will definitely get questions, just to confirm, when you said compound heterozygous, what did you really mean by this? And even though it's written there, they want that confirmation, which is great. That's exactly what I'm there for. So there's, I wouldn't say we get pushback, but we definitely do get calls to clarify the information on the report.
Okay, gracias. Seba, si quieres continuar.
Thank you so much. Sebastián, do you want to go on? Yes, I already have some questions ready for Jennifer. You mentioned, you talked about the risk for heterozygosis variant and the homozygous variants for ATM, for example. So the question is, what about the pre-test counseling? Do you tell them that they could have other variants come up, for example, related to cancer? And also considering that many times couples who are undergoing IVF, well, they don't really consider the fact that they may come up with some cancer risks. That's not something they have in their minds when they come in, right?
Exactly. Yes. So that's a really good question, because I have a lot of friends who work in the reproductive genetic space, talking to couples, in an OBGYN setting. And my friend and I were joking. She's like, I used to be a counselor that talked about, whether they were a carrier of cystic fibrosis. Now they're coming to me with these expanded carrier screening results. And I have to say, oh, now you need to see this oncology group for screening. And it's a huge, unexpected result. The bigger these panels get, the more now we're, a lot of people are getting 200 genes. Now we have 500. The more we add, the more we load on, make this problem bigger, depending on how you look at it, a good thing, but a bad thing too, from a counseling perspective. When I'm talking to patients, most of the time, it's not so much from the, oh my goodness, I just got my expanded carrier screening results, but it is often from the, oh my goodness, I just found out I'm an ATM variant and now I want PGT, and there hasn't been a discussion about the partner. And so I am definitely bringing up in that scenario, the at least the option, making them know that is available. I'm a little bit limited in my role, in that my personal role is really to focus on PGT testing. I'm not their clinician, which is sometimes a struggle for me, because I don't want to keep things to myself if I know something to help somebody. So I will definitely make available, the idea that this potentially could be recessive condition. And conversely, if we are talking about expanded carrier screening results, and I do see something on their report that potentially can be related to one of those risks, I will definitely want them to be referred to somebody who could dig into that deeper. But you're exactly right, that what we used to consider these traditional, this is cancer genetics, this is reproductive genetics and never they shall meet is not true. It is all very incestuous and clinicians need to know that.
Y con otros genes también, se me ocurría el gen
And
GBA.
other genes as well, maybe the Gaucher related gene or Parkinson, you know, it's also a risk, you know. So there could be other associated risks even beyond cancer, of course. So do you think that when you do the counseling, we should have in the informed consent, in the pretext for the expanded carrier screening, have some like a clause or additional clause or something related to this?
I do. I'm never against putting in a clause about important genetic information when patients are making a decision about a genetic test, whether it be expanded carrier screening, PGT, whatever the case may be. And I do think it's probably smart for, you know, when we're talking to patients about expanded carrier screening, to let them know that the main goal of this testing is to identify reproductive risks. However, the secondary potential finding may be, you know, X, Y, and Z, or, you know, finding out that you yourself may be at risk for a genetic condition, and that what would the next steps be? Follow up with, you know, other clinicians, etc. That I think is very wise.
Perfecto, gracias.
Perfect, thank you.
Yo paso, no sé si continúo.
Should I go on? Yes, I have more questions.
Vamos a preguntarle a Diego.
My question now is for Dr. Diego.
Diego, me pareció muy interesante el tema de
I really thought it was quite interesting, you know, these 20,000 regions that the NGS reads, and regarding resolution also,
se me generó una duda, es,
something came to mind,
¿por qué si
because
teóricamente NGS
if
tiene menos
theoretically
resolución que el
NGS has less resolution than the array,
ver alteraciones
then
de 3
you
megas,
can see 3 mega alterations and even less, but with the array you have 10 megas, or is it this 10 megas? Is it there
cautelosa, digamos,
for, you know, caution to make sure that something that you can see, but in fact you can see smaller alterations, which is what happened in the past, excuse me. There are a lot of labs that say 20, but in practice and with PGT as SR, excuse me, you can see smaller alterations, which are close to 3 megabases. Well, you already answered the question, because we want to take precautions, and I'm sure Jennifer will correct me if I'm wrong, but the SNP array, 800,000, well, you can see 1.5 megabases. But what happens is that, as I said, despite the fact that we see it, and it's something, if you see it, you report it. And we've seen cases where you can see in the X chromosome, we had all of the embryos with that. And even if it was really small, we made the report, and we, of course, that was something that was because that the patient had an anomaly. But why is it 10 megabases? Well, that's what's been validated so far to date. So we do report it. If we see it, we say it. But what we have available are up to 10 megabases. That's the basic answer. Okay, I understand. I imagine, but I wanted your confirmation.
And then talking about mosaic, how much do you believe that this affected, or how much influence did it have in the way how you conduct and do not report mosaics? How important was the previous information, years of experience with NGS and all the studies done studying the predictive value of NGS? What I mean is, if you were starting now with the array, would it be different scenario? Because now you start with the array platform, but the backend of previous information and knowledge is given by all the experience accumulated with NGS. I don't know how much you have used or how much you base on that result. Well, let me see if that is your question. The specific case is like Nathan. Genomic prediction has 5 years. Was using a QPCR platform for 10 years, and so it had been used for several years. So all this idea of mosaics, although there is a lot of publications from other sides, Nathan collected all the aneuploid embryos generated by a clinic, so there was a lot of aneuploid, and rebiopsying, and when the rebiopsies you could see next generation sequencing, QPSR, the confirmation of a reciprocal aneuploidia. We are talking about fertilization error, or the confirmation that it was a true mosaic that was found very little, 3%. So it was based on that data, on those data, where we started to challenge, because, well, this is clear. If we do not have the facility or all the embryos to fragment the study, we don't see it. And we base ourselves in the plots. So that helped a great deal. It doesn't mean that mosaicism does not exist. It does. It is documented. But when some clinics say 15% mosaicism, 20%, well, there is something that doesn't work here. It's just not right. I understand it was a complicated question, but that's what I meant. What background information you had used to determine how to proceed with mosaic. And a little, in a way, since you have been the pioneers, the first to use the SNP for PGD, what challenges did you encounter? Things that, what was the most complex, or the technology was simple, friendly, user friendly? What did you find? What did you come across? Well, I will give you the laboratory perspective, and Jennifer, you can give the genetic perspective. As genetists, I would say very frankly, the clone around time, because we say that, well, next generation sequencing, we can have a result in 3 days. A SNP array is 4 days of protocol of doing hybridization plus the amplification day. So the result takes 6 days. So that's one of the things that we as geneticians, and for the doctor, well, what happens? The advantage is that we are cryopreserving, but that was one of the main things. Level of costs and management of the laboratory workflow. It's a matter of getting used to the change. But yes, I would say that the runtime was one of the most difficult things. Yeah, array protocols. I have experience. I have no experience with SNP, but array CGA array is something different. High throughput as it permit to put the play in, and that's it. But the next day, 23 hours, well, you have to measure it. But yeah, basically that's it. Thank you. Well, one question for Diego, the clinical aspect. We want to know your opinion about non-invasive PGT. How do you see it? Do you use it? What you can tell us? Well, yes, non-invasive PGT, we are talking about the PGT then in the culture medium, because non-invasive, quote unquote, because the protocol say, oh, you have to, it's not exactly, we prefer to use cell-free. So this is, we as embryologists think it is ideal. And when you see that in the market and you buy the test, that creates expectations. What happens is where the concordances and where it is the work that is saying that it is comparable to equal to the PGT in the biopsy. There are a lot of people working on this, Carmen, other sites, but until so far, you may see that concordance not only employed or unemployed, but also in they are still not 90%. And that's what we need because it is a result that is not just anything, it's not something that it can, and therefore we have a line of investigation that we have not published because the concordances are low. It'll be published in due time, and how much the non-invasive protocol will change the flow in the embryology laboratory because it is something different. When we talk about non-invasive, it has to go hand in hand because the medium collection protocols are different, contamination, single drop, monophasic or sequential. So there are many details, but I would say that so far it is something that shines. Not all that glitters is gold, but if we could do something more rigorous, yes, in future, maybe a protocol is useful for certain clinic, but like in general test, perhaps you can prioritize, but sometimes it's like flipping a coin. Thank you, very clear. If we have any more questions, anything anyone would like to ask something? Well, I have another question for Jennifer, very brief, very short. Jennifer, I am curious of how you manage counseling of PGTM, taking into consideration the report gets PGT-A and M together. Is there any case in the couple that can have many embryos or produce many embryos in which perhaps they have only one embryo in which does not have the mutation but aneuploidy? Is there any case in which you consider to counsel or the partner thinks of transferring or not? How do you manage that?
That's a really good question. And we're actually, when we're designing our reports, we try very hard not to put a spin on the results in terms of saying do not transfer versus transfer. And certainly for PGTM, for all the reasons I talked about before, that's very important because of the depth and breadth of conditions we're looking at. For PGTA, it's a little bit different, but we do try to just literally categorize embryos as euploid or aneuploid. Because we're not reporting mosaicism, we're not fielding those questions, at least on our reports about mosaicism. We field lots of questions about it, but not relating specifically to the results we're given. I would say certainly it would make sense if a couple has, 3 embryos, let's say, and 2 are affected with, the disease that they're worried about, and one has Klinefelter syndrome, an XXY or XXX. On a personal level, I certainly wouldn't see a reason why that couple would necessarily need to take that particular embryo with a sex chromosome anomaly out of their cohort if that's the only option that they have, because potentially that sex chromosome issue can very well be much, much less severe than the condition the PGTM condition that they're worried about. Outside of that, it gets a little bit trickier. Certainly if a couple themselves is amenable to transferring an embryo with trisomy 21, certainly, my personal belief is that they should have that reproductive liberty to do that. That of course depends on whether they're able to, based on what their IVF center says and all of, those other things. But so I would counsel a couple that if that was an option for them, then that's something they should discuss with their IVF team. Outside of that, because we're so worried about implantation failure and miscarriage and significant health issues in a pregnancy that would go to term, the remaining chromosome issues, that's a different story. And I would counsel the patients, of exactly that, and the reasons why we generally consider embryos that are aneuploid not suitable for transfer for those reasons.
Okay, gracias.
Yeah.
Bueno, me parece que
Well, at least for this meeting, we have obtained a lot of information. Thank you very much. We have no more time to share, but we may have that in another occasion. Thank you, Jennifer, Diego, Cecilia, Sebastián, Andrea, who's here with us, the technical support, the participants, the interpreters, everyone, and the companies that help with the sponsoring to support this communication that is very enriching to us all. Thank you for being so kind with your time and your knowledge. We will meet in the future. Let me tell you that June 15th, we have the upcoming session with the Boston IVF group, a second exchange session. So thank you very much for being here with us.